Sedation.
Perfect. So, welcome everybody, 7:30 or a bit after, sorry for being a little bit late, to this Geeks webinar on sedation and patient comfort. We're really excited. I think this is something new in this space. I've been approached by a lot of people who have talked to me ESG days recently and the like about that. They want to get the content of this webinar because they really are interested in this topic, and I think it's therefore clearly very relevant to the current day. I'm joined by Standard Geeks faculty and my co-founders Roland Valori and John Anderson, and I'm also very, very happy to be joined by Dr. Manmeet Matharu from St. Mark's in London and Dr. Catherine van der Water from Roeselare Hospital in Belgium. We're so privileged to be joined by these two, and we'll introduce them as the talk goes further. I think one thing we really want to nail here is the system and how sedation is really a big part of the system, and the system counts for the hospital, the procedure room, the people in it, anaesthetists, gastroenterologists, nurses, and the stuff that you have around. Because I think it's quite established that this can quite commonly go wrong, sedation, and when it goes wrong, it's a complete disaster, and people sometimes come to serious harm because of it. So we need to get it right, and hopefully after tonight you can understand a lot of the issues and the way to get it right. We're focusing tonight on 4 domains of sedation. So the first part is colonoscopy focused, and can it be with less sedation? Where's the sweet spot? We're talking about safety. We're talking about anesthesia, and particularly the role of the anesthetist. We're so privileged to have an anesthetist with us to discuss where the sweet spot is between us and her as to who exactly needs the anesthetic care that they can so adequately provide. And then what happens next Monday when we want to change our practice. So I'd like to introduce the first speaker of tonight. He needs very little introduction in this context, but he is Dr. Roland Valori. He is, I think, previously still working at Gloucestershire Hospital's NHS Foundation Trust in the UK, is now, I think, working for himself and living a bit between there and in London. He's the former National Clinical Director for Endoscopy in England, and he has had many, many roles in healthcare, quality in healthcare, and healthcare delivery. Roland, it's a privilege to introduce you, and I'll invite you to take the floor to chair the rest of the webinar and to start with your presentation on sedation in colonoscopy. Thank you very much.
Thanks very much, David. And thank you for that kind introduction. Can you see my presentation?
Yeah, we can. Perfect. Yeah.
So, yeah, thank you. I think this is very, very important, and I'm very pleased that we've got some fantastic faculty with us today. So, the Academy of Medical Royal Colleges, which is the sort of parent college of all the main royal colleges in the UK, did a safe sedation update a few years ago, and they referred to the American Society of Anesthesiologists levels of sedation. I think this is really important, and you can read for yourselves what those levels of sedation are. And what's really interesting for me preparing for this webinar is that really I rarely have my patients more sedated than minimal sedation. I'd always use the term conscious sedation, but according to the definitions here, all of my patients are very lightly sedated, and I can usually chat with them, and that's one of the joys of having lightly sedated patients, is you can talk to them and find out all sorts of interesting things about them. Now, there is, I would say, and I think it's a fair word, extreme variation in sedation practice across the world for everyday endoscopy. So we're talking here mainly about colonoscopy today. I mean, we can talk about ERCP in the US and complex endoscopy, but really the great variation is within the everyday practice. And the variation goes from no or minimal sedation, as defined by the ASA, to general anesthesia. So I pose a few questions here. Is this variation warranted? Can either extreme be justified? And who is right? And I hope what we'll conclude from this webinar, because that's certainly the position where I'm coming from, is that I think everyone in all settings can do better I think there is room for improvement, and I hope we can reach some sort of consensus about what that might look like. Now, I downloaded this data from the NED, the National Endoscopy Database, this morning, and it's all the colonoscopies that have been done in our hospital in the last sort of 15 months, something like that, since the beginning of 2015.